Large amount of data of the trials focuses on people above the age of 50. So middle age, elderly, and very old are represented in the trials. Why they are represented there? Because cardiovascular risk starts somewhere around 60 in Western countries. In India, maybe around 50. So initially, they thought that people below the age of 40 are kind of protected, and we need not do anything to them in that age group. It's only at the age of 50 that we need to start thinking about it. So large number of data has accumulated about the role of hypertension, its consequences in terms of cardiovascular, renal, heart failure events, and its prevention by variety of antihypertensive therapies and combination. Young people below the age of 40 are not very well represented. Practically, if you change the threshold from 140/90 to 130/80, your incidence or your prevalence of hypertension almost doubles. When he comes to the clinic, he has not smoked for a couple of hours, pressure is down. As soon as he takes a cigar, nicotine kicks in and his pressure goes up. So throughout the day, his pressures are elevated, nocturnal pressures are elevated, nocturnal DP is not much. And this is a classical example of a masked hypertension. Studies suggest that there are large number of young people with raised blood pressure, 20-30%. So 1 in 5 or 1 in 3 young adult might be hypertensive, and left untreated, they are likely to suffer from avoidable premature cardiovascular mortality and morbidity.
Hello, thank you for tuning in. If you want to come back to this video later, just tap on the like button. It will save it to your liked videos so it's easier to find. And don't forget to hit on the bell icon to get notified whenever we drop new content. Stay curious, keep learning, and see you on the inside.
Good evening, friends. Today's topic is a little offbeat. Why did I think of young hypertension? We have lots and lots of CMEs on hypertension, and practically every new molecule, every new strength, or every new combination of antihypertensive medication comes. Every new guideline which gets published, whether it's European, American, or Indian, there are dozens of CMEs sponsored by the companies. But hardly ever we talk about hypertension in young. So I thought that this would be the right time when we should be thinking about it. And at the end of this session, I'm sure you'll be convinced that this particular aspect of hypertension needs to be taken far more seriously. Well, when we say young hypertension, we mean that it is below the age of 40. The age bands which are defined in terms of age bands which are defined for medical, social, legal parlance is middle age between 40 to 64, older adult or elderly between 65 to 79, very old are 80 plus, and of course, people who have finished the century, centenarians are also there, but they are very few and far in between. Large amount of data of the trials focuses on people above the age of 50. So middle age, elderly, and very old are represented in the trials. Why they are represented there? Because cardiovascular risk starts somewhere around 60 in Western countries. In India, maybe around 50. So initially, they thought that people below the age of 40 are kind of protected, and we need not do anything to them in that age group. It's only at the age of 50 that we need to start thinking about it. So large number of data has accumulated about the role of hypertension, its consequences in terms of cardiovascular, renal, heart failure events, and its prevention by variety of antihypertensive therapies and combination. Young people below the age of 40 are not very well represented. As an adult cardiologist, I should be thinking about only between the age of 18 to 39. But the neonatal, which is defined as age below between 0 to 28 days, infants between 28 days to 1 year, children between 0 to 18 years, adolescents 10 to 19, and youth defined as between 15 to 24 years. Even in those age group, there are certain markers, there are certain parameters, there are certain uh, kind of incidence and prevalence which have a bearing on the patient's future hypertension as well as its consequences. So, a couple of slides I'm going to talk about hypertension in children too. So there is a lack of focus in people below the age of 40 so far as hypertension is concerned. That is because below the age of 40 they have a very less contact with the healthcare system. They don't fall ill very frequently, and that's why they do not contact their family physician very frequently. Whenever they contact, despite regular physician visit, blood pressure is not being measured because there are no strong guidelines in this age group, and that's why they they risk underestimation of the risk by both patient as well as providers, clinicians. And young people, they feel invincible, nothing is going to happen, and that mindset. Why do we focus on people below the age of 40 today? Majority of trials are focused on people above the age of 50 because cardiovascular events, infarct, strokes, heart failure, kidney failure, starts at the age of 60 in Western countries, maybe 8-10 years earlier in this part of the world. And that is why they feel that below the age of 40 the trials did not include the patients. Majority of trials, they started with the age of 50 or 40 and things like that. And that is the reason we have large amount of data in middle age, elderly, and very old. But in young adults between 18 to 39, we don't have much data. And if you talk about the pediatric age, the neonates 0 to 28 days, infants 28 days to 1 year, children between 0 to 18 years, adolescents between 10 to 19 years, there is an extreme sparsity of data. But that does carry any increased blood pressure even in pediatric age, carries a adverse connotation so far as cardiovascular event and future hypertension is concerned. So couple of slides I'm also going to talk about pediatric hypertension. There is a lack of focus below the age of 40 because there is a low health system contact. People below the age of 40 do not fall ill that much, they don't contact the GP. If they contact the GP, they do not focus on blood pressure, they do not measure it, so it does not get detected. So there is a kind of ignorance, or they don't focus on it, both patients and providers. And young people, they feel invincible, nothing is going to happen to them, and in fact up to the age of 50, 55, 60, nothing is likely to happen. But when it happens, we have already missed the bus. Why? Because early onset hypertension confers a long and a lifetime exposure. Even a small increase in blood pressure, if the person is exposed to a long number of years, say 20, 30 years, it causes cumulative end organ damage. End organ damage which does not get reversed or does not get reversed easily. Secondly, the secondary hypertension, hypertension where there is a specific treated curable etiology, is disproportionately more common in younger and hypertensive patients. We are going to see that in detail. Certain phenotypes of hypertension like masked hypertension or isolated systolic hypertension, isolated diastolic hypertension is more common in younger people, which is associated with different pathophysiology, and which, in my opinion and in the opinions of the experts around the world, that they need to be taken more seriously and they need to be managed in a little different way than the classical antihypertensive medication which we choose. So these people do not get investigated much because 10-year risk is not very high, but the lifetime risk is much higher. So much so that even the risk calculators which are available, they do not focus on people below the age of 40. And if you see the normative data, what is normal blood pressure, people above the age of 40, people below the age of 40, the normal blood pressure, if you find, it is lower in the younger people than elderly. So probably definition of hypertension also might need a lower cutoff values than what is currently known. What is the global prevalence? How common is hypertension in young adults? It varies, depends upon the diagnostic thresholds and the population which you studied. So direct comparison between populations is not possible. For example, in England, 9% of the adults, young adults, have hypertension. That was the data between 16 to 44 years, 2021 data, and the cutoff value which was used was 140 by 90. In US, where the guidelines are more aggressive, the blood pressure cutoffs are the diagnostic cutoff for hypertension is 130 by 80, and between 17 and 18, when they judged the young hypertensive population, the incidence was found was 20%. So practically, if you change the threshold from 140/90 to 130/80, your incidence or your prevalence of hypertension almost doubles. And in children and adolescents, in meta-analysis of the global prevalence in children below the age of 19, defined as normal blood pressure was defined as uh, blood pressure more than 120 by 80 or 19th percentile for age, sex, and height. So in children, you define blood pressure in terms of age, gender, and height. All three variables have to be taken care of, and there are charts and graphs available wherein you put individual patients' data and you find out whether the patient is falling below 90th percentile, then it is normal. Above 90th percentile, it is called elevated blood pressure, and above 95th percentile, it is known as hypertension. So 2 to 5% of the children fell in the 95th percentile and above, so hypertensive, and almost 15% of the children were falling into the criteria of elevated blood pressure, which is more than 90th percentile. And this has been known to increase over time. What data or prevalence was there in 1994, in 2018, it is much higher. Now, important point to remember is childhood blood pressure is a strong predictor of adult hypertension and metabolic syndrome. It is an intermediate cardiovascular risk disease predictor. It's not definitely not low, not very high. 7% of them are likely to progress to hypertension every year, and there is an accelerated vascular aging. Once the vascular aging happens, your survival goes down, your major adverse cardiovascular event goes up. And the intermediate markers of cardiovascular disease like left ventricular mass, carotid intima media thickness, and pulse wave velocity, they are all found to be worse in children with elevated or hypertensive range blood pressure. What are the Indian data? Well, here National Adult Health and Nutritional Survey, National Adult Health and Nutritional Survey 2025, and there they collected National Family Health Survey data. National Family Health Survey, that was the fifth survey in India, all 28 states, 8 union territories, 700 plus districts, 6 lakh plus households were evaluated. Blood pressure was diagnosed at more than 140 or 90, and it was also subdivided. We are not going to go into the detail, and that was also defined by American Heart Association criteria 130/80. And what prevalence we got depending upon what criteria we used. If you used 140/90 criteria, National Family Health Survey 5, then 21% of women between the age of 15 to 49 were hypertensive, and men 24% between the age of 15 to 54. And if the criteria were relaxed to above 130/80, then 45% of women and 62% of men were found to have either elevated blood pressure or hypertension. That's a very startling data, much higher prevalence than what we see in the Western countries. And this is just an example of a nomogram or a chart wherein we can see the normal blood pressure. This is for infants. So infants at day 4, day 7, and day 14, systolic and diastolic blood pressure, and these are the percentiles. If somebody is above 95th percentile, then they are supposed to be hypertensive. So for example, at day 14, if the patient was born at full term, any systolic blood pressure above 90 is hypertension, and corresponding data for diastolic pressure is 70. Like that, we have data for pediatric age group between the age of 1 and 13 also, and that needs to be referenced to nowadays with the AI and online platforms. You can just put in the patient's height, gender, and details, and you can find out whether patient falls above 90th percentile or above 95th percentile. In adults, we say that attended office blood pressure or clinic BP above 140/90 is the cutoff. Ambulatory blood pressure, the same cutoffs are 135/85, which is same as a home blood pressure or self-monitored blood pressure, 135/85. Ambulatory 24-hour mean, if you see, cutoff is 130/80, and ambulatory night cutoff is 120/70. Below the age of 13, you have to see the percentile charts and define whether the patient has a normal blood pressure less than 90th percentile, elevated blood pressure between 90 to 95th percentile, and hypertension above 19th percentile, and stage 2 hypertension 95th percentile plus 12 millimeter mercury. At any point of time, if it crosses the adult range, which are normative for normal, elevated, or high blood pressure, then it should be defined in those category. In children above the age of 13, practically adult criteria are being used for diagnosis of hypertension. How do you evaluate and manage a young hypertensive patient? Most important thing is, because these people have very high variability, very high incidence of white coat hypertension, masked hypertension, it is important that we focus on the technique of measuring blood pressure. It's very unfortunate to say that large number of people, myself included, equally guilty of not measuring blood pressure properly. When you have to take care of blood pressure, measure blood pressure properly, you have to take care of how the patient is sitting. Legs should be supported, back should be supported, blood pressure measure machine should be validated, cuff should be of adequate size, patient should have relaxed, bladder should be empty, 5 minutes of rest, 2 hours of stomach rest, means no tea, coffee, or meal before that. All those parameters should be measured multiple times. It should be measured. First time when you measure, it should be done on both the arms, and it should be repeated on 2 or 3 different occasions, unless the patient has, of course, severely elevated blood pressure, before you come to conclusion that this patient has hypertension. That is to take care of blood pressure variability, which is inherent, and allergic response when the cough inflates or the patient enters the clinic, the white coat effect comes into way. All those things should be taken care of. Ambulatory blood pressure and home blood pressure monitoring should be used far more frequently than we use it in adult patients, because of the inherent variability which is much more common in this group of patients. And if you see over here, this is the ambulatory blood pressure chart. This is systolic blood pressure. This is diastolic blood pressure. This is daytime cutoff, which is 140, and nighttime cutoff, which is 125. And again, patient wakes up. Here you can see in the clinic, when the blood pressure is machine is connected, the pressures are 150, 160. As soon as he leaves clinic, blood pressure drops, remains below the daytime threshold, remains below the nighttime threshold, till his machine is disconnected. This is a classical EBPM chart of a white coat hypertension. And here, if you see, when the ABPM is connected, the patient's blood pressure is 130. He is not hypertensive by clinic blood pressure. As soon as he leaves clinic, he faces his normal life challenges of his work at his home atmosphere, maybe sleep apnea, maybe he is smoking, maybe he is taking alcohol, which adds to the variability. And hence, when he comes to the clinic, he has not smoked for a couple of hours, pressure is down. As soon as he takes a cigar, nicotine kicks in and his pressure goes up. So throughout the day, his pressures are elevated, nocturnal pressures are elevated, nocturnal DP is not much. And this is a classical example of a masked hypertension. How frequent they are, this one very clearly shows the blood pressure measured in office can be normal or abnormal. Blood pressure measured outside office, home blood pressure or ambulatory blood pressure, again it can be normal or abnormal. If both are normal, patient is true normotensive. Office normal, home BP normal. If both are elevated, office BP elevated, home BP elevated, it is sustained hypertension. If the patient's office blood pressure is on higher side, at home blood pressure is normal, these are white coat hypertensives. And if the office blood pressure is his office blood pressure is normal and his home blood pressure is elevated, that falls into the masked hypertension category. Out of all the population, almost 50% are true normotensive, around 30% are hypertensive. Of that, masked hypertension falls to around 15-20%, and white coat hypertension falls into something like 20 to 30%. That is something which is very common, and in my clinical practice nowadays, I ask almost every patient with hypertension, except those who are very mild hypertension and they are very well settled. Everyone has to measure blood pressure at home and come. I do not rely on the blood pressure measured in my clinic for majority of patients to initiate antihypertensive therapy, to titrate antihypertensive therapy up or down. These are the factors leading to hypertension in the young. They are not much different from what we find in elderly population. Psychological factors like ethnicity, socioeconomic status, mental health, metabolic influences like diabetes, metabolic syndrome, variety of hormonal conditions, diet and sleep issues like high salt intake, poor diet quality, sleep duration, sleep disruptions, etc. Energy balance like obesity, central adiposity, genetic influence, monogenic or polygenic influences on hypertension, family history of hypertension, which is an overlapping factor for genetic, premature birth, low birth weight also contributes to an incidence of hypertension. Medical factors like lack of preventing care, etc., also contributes to hypertension, and all those things contribute to consequences of variety of organ damage. Now we talked about higher incidence of secondary causes in elderly people. When we see and when we screen them for secondary causes, we find secondary cause hardly in 5 or 7% of people. So it is not routine to screen every elderly person who presents with hypertension for screening for secondary causes unless there are clinical or laboratory markers, pointers towards possibility of secondary hypertension. But what happens in young adults? This is a cohort of 2090 patients. 29%, almost 30% of them had secondary hypertension. And out of that 30% cohort, which is 619 patients out of 2019, 55% had primary hyperaldosteronism, 18% had renovascular hypertension, which could be atherosclerotic renal artery disease or fibromuscular dysplasia. Primary renal disease or medical renal disease, what we call, accounted for almost 13% of patients. Pheochromocytoma, 6%. Drug or substance abuse, 6%, and other diagnoses like sleep apnea, etc., 2.7%. So these parameters need to be kept in mind when you are evaluating, and at a drop of a hat, on slightest suspicion, you should be doing an extensive investigations for secondary causes for hypertension. What are the investigations which we look for? If you are suspecting resistant hypertension, hypokalemia, very young onset hypertension, think of primary hyperaldosteronism and do an aldosterone renin ratio. Easier said than done. It's not a very easy test. Lot of preparation is required. Lot of interpreting factors are required to look into. Lot of different methodologies are used. Lot of different units are used in their interpretation. So it's a very complex subject. Plasma metanephrines will help in patients who have episodic symptoms like headache, palpitation, sweating, etc. when you're suspecting pheochromocytoma. 24-hour urine is helpful in checking cortisol levels, which is helpful in Cushing syndrome. Albuminuria will help you define primary medical renal disease. 24-hour sodium level will tell you how much salt patient is consuming. Renal Doppler and abdominal CT will tell you about renovascular hypertension, because renal arteries will be imaged in those patients. And if you're suspecting parathyroid hormone, largely you suspect based calcium levels in renal profile, then you have to do parathyroid hormone levels, etc. What are the medications that can interfere with blood pressure control? And for this, you need to take a very meticulous history. NSAIDs, non-steroidal anti-inflammatory agents, including aspirin, COX-2 inhibitors, even acetaminophen, when taken in large dose for a longer period, can contribute to hypertension. Sympathomimetic agents like decongestants, diet pills, cocaine, caffeine, even there's some Chinese medicine which contains ginseng. It is supposed to be sympathomimetic. Stimulants, methamphetamine, etc., can contribute to it. Steroids will increase hypertension. Modafinil, if you are giving for daytime sleepiness. Alcohol, when taken, it reduces blood pressure for a couple of hours, followed by sustained rise. Oral contraceptives, certain anti-cancer agents, erythropoietin being used for anemia and renal failure patients, licorice, chewing tobacco, and variety of herbal compounds, then they can contribute. And meticulous history taking is extremely important in this group of patients. Practically, I feel every patient who is hypertensive, who is defined hypertensive by multiple proper blood pressure reading, including out of office blood pressure reading, needs to have a good screening for secondary hypertension. And European Society of Hypertension flags that any young onset hypertension with second or third degree hypertension, resistant hypertension, is a priority trigger for workup for secondary hypertension. If you are not comfortable with that workup, a referral is required. End organ damage is an important parameter to decide whether a particular patient needs antihypertensive treatment or not. More importantly, in borderline cases, so what are the end organ damages in heart? It could be LV systolic or diastolic dysfunction. Echocardiography or NT-pro BNP is going to help you out. Chronic kidney disease, you have a lower threshold of treating. Microalbuminuria, proteinuria, declining EGFR, or medical renal disease as demonstrated on ultrasound examination can help you that. Visual impairment, hypertensive retinopathy needs to be looked into, hemorrhages, microaneurysms, exudates, etc. If the patient has lacunar infarcts, microbleeds, or a major infarct, TIA, etc., obviously that hypertension needs to be taken seriously. And peripheral vascular disease, aortic aneurysm, they all point toward more malignant nature of that particular hypertensive pathophysiology and needs to be treated. In very young people, in children, you find hypertension, you have to think of monogenic hypertension, single gene disorders. There are variety of disorders. I'm not going to read them all, but large number of disorders like Liddle syndrome, Golden syndrome, Geller syndrome, familial hyperaldosteronism, and they all need specific therapy for each disease. So genetic analysis, family counseling, family screening, etc., could be the way to detect this kind of monogenic hypertension. Risk stratification is another important tool to decide the long-term therapy for a young patient with hypertension. Unfortunately, majority of risk factors, they focus on people above the age of 40. Like for example, ASCOD risk calculator or pooled cohort risk calculator does not accept the patients below the age of 40 because simply they don't have data. QRisk Lifetime and a recently published Prevent Risk Calculator are the ones which starts calculating risk at the age of 30, and that might be helpful in quantifying exactly what is the patient's next 10 years ASCOD risk or a lifetime ASCOD risk. Now, how do you manage these patients? Lifestyle is obviously very important. It should be given a serious thought. Dash diet can reduce your blood pressure by 3 to 7 systolic, 2 to 4 diastolic. Uh, Combine them with a severe sodium restriction, aerobic exercise, weight loss, avoiding all stimulants, whatever you have got in history, you take care of all those things. And here you can see what is an average blood pressure reduction you can expect with each of the lifestyle modification, like weight reduction, maintain BMI between 20 to 25, 5 to 10 millimeter of mercury per 10 kg weight loss is expected. Diet rich in fruit, vegetables, and low in salt, 8 to 14, 2 to 8 millimeter mercury drop. Physical activity, 4 to 9 millimeter mercury systolic drop, and alcohol moderation, 2 to 4. When you combine together, 10 to 20 millimeter of mercury drop is not something which is surprising or unusual. How about pharmacotherapy, first line choices? Of course, when first line choice fails, your sequential choices remains more or less similar. Even in first line therapy, there is no great difference than the elderly hypertensives. First line therapies are diuretics, thyroid thiazide or thiazide like hydrochlorothiazide, chlorothalidone, indapamide. ACE inhibitors, if not tolerated, ARBs, calcium channel blockers would be the standard first line therapy or first line single pill combination therapy if the patient has more than stage 1 hypertension. But depending upon selected comorbidities, tolerability of the patient, pregnancy plans of the patient, the choices might differ, and those opportunities are more common to be more selective than the standard antihypertensive therapy. Beta blockers are generally not the first line therapy for uncomplicated hypertension in ACCHA, but European Society of Hypertension 2023 looked at the data more meticulously, and they have come out with a more liberal indication for beta blocker in hypertension, which is particularly applicable to young hypertensive. Your targets are 130 by 80 because we are not worried about postural hypertension, fall, and fracture, what happens in very elderly people above the age of 75, 80. So your targets are stricter below 130, 80. And even if you achieve 120, 75, patient is asymptomatic, I would not de-escalate the therapy, but look for any orthostatic symptoms, etc. Reassess the patient every couple of weeks, maybe 4 to 6 weeks, preferably home blood pressure monitoring or ambulatory blood pressure monitoring once in a year to titrate the therapy up or down and de escalate the therapy if the patient has symptomatic hypertension. What about pregnancy? For women who are pregnant or planning to be pregnant, the thing to be avoided is all RAS system, ACE inhibitors, ARBs, mineralocorticoid receptor agonists, antagonists, and ARNI. All those things are strongly contraindicated. Even if the patient is planning to be pregnant, I would ask the patient to discontinue therapy at least 2 to 3 months before they plan for a pregnancy. And in pregnant patients, the choice of agent is labetalol, which is classical, but other beta blockers can be used, particularly bisoprolol, metoprolol. Nifedipine is a classical calcium channel blocker, which has the highest data, but even amlodipine is routinely used. Methyl dopa, central alpha agonist, which reduces the sympathetic drive, is also one of the commonly used agent. Now, the young patients are likely to be physically very much active. They would like to do a lot of heavy exercises, playing games, or some of them might might like to follow the athletic career. And those things need to be factored into when you are planning therapy. Regular aerobic exercise is recommended for all hypertensive patients, and competitive sport participation is permissible when BP is controlled and no high risk organ damage is present. If BP remains more than 140/90 and or there is a hypertensive mediated end organ damage, there is a risk of arrhythmias, power sports are to be restricted. Very competitive sports, aggressive sports are to be restricted, and some of the athletes might have to terminate their career and look for other alternative routes of their professional engagement. This is British and Ireland Hypertension Society recommendation. This is not evidence based because we don't have a great amount of data for young hypertensive patients. Hypertension is confirmed as 135 by 85 in out of office. In office, it will be 140 by 90 equivalent. If blood pressure is more than 180 by 120, then straightway start with the single pill combination dual or trickle drug therapy. If BP is between 160 to 180, again investigate for secondary hypertension and lifestyle in a short while within 3 months. If lifestyle does not bring down the blood pressure, uh, uh, then pharmacotherapy has to be used. If it is controlled, long-term management. If it is not controlled, escalate therapy every couple of months. If the blood pressure is below 160 by 100, and if the patient does not have cardiovascular disease, diabetes, renal disease, and his Q risk 3 score is less than is more than 10. If the patient has any of this condition, start with antihypertensive therapy. If he does not have, then look for hypertensive end organ damage, left ventricular hypertrophy, etc. If it is there, again you treat this patient. If it is not there, then give 6 to 12 months of lifestyle modification. If it fails to control blood pressure, start antihypertensive therapy. That is the flow chart for hypertension management. Now that practically covers every aspect of it. Still, I have a significant number of slides left out. You will be wondering what. Let us talk about different phenotypes of hypertension. Although hypertension is viewed as a single condition with a single line of therapy, standard antihypertensive therapy, but there are different pathophysiologies which might be acting isolated or in combination with different pathophysiologies, and that can manifest as isolated systolic hypertension, isolated diastolic hypertension, or systolic hypertension. Different hemodynamic mechanisms they have. Isolated systolic hypertension is most common form of hypertension in young adults. It is more common in males and obese. The mechanism is elevated cardiac output. In my opinion, it is largely driven by increased sympathetic drive in younger population, which increases the cardiac contractility, increases the heart rate, increases the stroke volume, and when the large amount of stroke volume enters the aorta, systolic pressure goes up. And since the aorta is not very stiff, diastolic pressure may not go up. Since peripheral vascular resistance may not have gone up, his diastolic pressure may not go up. A small number of young subjects who were hypertensive from early childhood, they might have developed uh, they might have developed small vessel disease, and with those small vessel disease, peripheral vascular resistance goes up, and that's why they might have an isolated systolic hypertension. Systolodiastolic hypertension and isolated diastolic hypertension have similar pathophysiology, increased peripheral vascular resistance. It's common in hypertensive. It's a common in young females. Peripheral vascular resistance has gone up, and sometimes there is an elevated aortic stiffness also, which is found in these patients. So basically, we have cardiac or vascular blood pressure phenotypes. Cardiac phenotypes, young males, obesity, you might think of using beta blockers as a first line therapy, or young females, peripheral vascular resistance has gone up, then vasodilating agents like RAS blockade or calcium channel blockers might be the agents of choice in this group of patients. Here you can see age-wise distribution of isolated diastolic hypertension, isolated systolic hypertension, the red bar, and overall hypertension. The overall incidence keeps on going up as the age advances, but if you can see the uh, isolated diastolic hypertension peaks somewhere around the age of 40, and then the vascular stiffness, aortic stiffness keeps on increasing, diastolic pressure keeps on falling, and in very elderly people, many times we find 160 by 60 blood pressure. That is because the aortic stiffness is there. Isolated systolic hypertension, vascular stifler related, keeps on going up over here, and sympathetic mediated isolated systolic hypertension because of increased stroke volume is found in patients with younger population. In a multicentric cohort of young hypertensive, isolated systolic hypertension prevalence was 2.7%, 5% in men, 1% in women. And longitudinal data suggests that some isolated systolic hypertension patient carries increased cardiovascular mortality risk, 90% increase, 1.9 hazard ratio. All cases may not be benign. Uh, Sometimes it might be because of the pure pulse pressure amplification. Central aortic pressure is normal, patient is very tall and very fit. So peripherally, you might find that blood pressure is on higher side. But if you do a central aortic measurement, that there are certain blood pressure machines available which based on peripheral blood pressure and pulse waveform analysis tells you about the calculated central aortic pressure. And if central aortic pressure is normal, you don't have to worry about, just keep them under regular observation. But sympathetic overdrive, hyperkinetic circulation, increased stroke volume, increased cardiac output possibly needs to be treated. And there is a phenotype which is combination of both the thing. So this is the comparison of isolated systolic hypertension of young and elderly. Prevalence is 1.5 to 5%, while in elderly, almost 30% of the patients have isolated systolic hypertension. Central blood pressure may be normal in spurious cases if the central pressure is elevated, then only it needs to be treated. Typically, in elderly isolated systolic hypertension, systolic pressure is elevated. Prognosis is mixed. Spurious hypertension in young patients does not carry any high mortality. Did not true, but true isolated systolic hypertension needs to be treated. While in elderly people, isolated systolic hypertension, n number of trials, HIVET and CSUR trial showed very clearly that it needs to be treated very aggressively, and management we have already discussed. What is the mechanism and prognosis of isolated diastolic hypertension? Young adults, it typically reflects increased peripheral vascular resistance. Small arteries are remodeled. Heightened sympathetic activity, neurohumoral activation is the basis for this. It is found more common in obese patient, obstructive sleep apnea, people using stimulants, or people who have a high stress during their life, either domestic or work related stress. And they need to be treated continuously. Now let us talk about, they need to be treated on a universal basis, on an aggressive basis, as aggressive as in elderly population. Let's talk about sympathetic overdrive. Sympathetic overdrive is a sustained increase in the central sympathetic outflow and efferent traffic to heart, blood pressure, kidney, etc., which elevates blood pressure by vasoconstriction, tachycardia, increased ionotropy, sodium retention, renal release. It can be measured by mean sympathetic nerve activity by microneurography. You put fine needles into the nerves in the forearm and you measure the sympathetic activity, or organ specific norepinephrine spillover are the gold standards. Heart rate variability, plasma norepinephrine levels are supportive but surrogate markers. They are not as specific as the gold standards. The clinical impact is hypertension severity. It contributes to endothelial dysfunction. And if you find sympathetic overdrive, now we have a European Society guidelines which tells you that uh, beta blockers. Now, why beta blockers are or were not first line therapy? Because in the meta-analysis of patients, almost 1,45,000 patients, 21 hypertension trials, it was found that beta blockers were less effective in reducing CV outcomes. The increased risk was almost 6%, statistically significant. But when the same meta-analysis younger population subgroup was analyzed, it was found that beta blockers were as effective as any other agent. People with increased sympathetic drive, you will find benefit of using beta blockers. So this is the guidelines I was talking about. 2017 US guidelines did not mention specific use of beta blocker as first line therapy unless patient has a comorbidity like ischemic heart disease, angina, infarction, heart failure, pregnancy, etc. But 2023 European Society of Hypertension guidelines very clearly mentioned that high resting heart rate more than 80 indicative of sympathetic overactivation, you can consider use of beta blocker as the first line therapy. Which beta blocker to use? Probably third generation beta blocker, super selective beta blocker, so that the patient does not have the side effect of erectile dysfunction or peripheral extremity perfusion, which might limit the patient's physical activity or athletic performance. And vasodilating beta blockers would be all the more applicable to this group of patients. How do we therapeutically target sympathetic tone? You can also use clonidine or preferably moxonidine, which is a more selective alpha 2 agonist. It reduces the central sympathetic drive and sympathetic nerve activity is known to reduce. Apart from beta blocker, you can also use renal denervation in appropriate cases. Renal denervation is coming in a big way in management of resistant hypertension, and it can be used in selected subgroup of patients. Lifestyle modification, exercise training, we know that it improves the vagal tone, decreases the sympathetic tone, should be given a first trial in patients where you are suspecting sympathetic overdrive. So, friends, hypertension tracks from neonate to child to young adult to elderly to very old. It increases the cardiovascular risk across the continuum of age. Studies suggest that there are large number of young people with raised blood pressure, 20-30%. So 1 in 5 or 1 in 3 young adult might be hypertensive, and left untreated, they are likely to suffer from avoidable premature cardiovascular mortality and morbidity. Use of ABPM and home blood pressure monitoring is strongly encouraged to avoid misclassification and for a proper guidance of therapy. Systematically screen for phenotypes and secondary causes. Systematically look for sympathetic overdrive. Aim for less than 130 by 80 if tolerated in with lifestyle, plus individualized choice for antihypertensive medication. Consider referral or co-manage the patient when the patient has severe hypertension, when there is a suspected secondary cause, refractory blood pressure on more than three class of drugs, severe hypertension mediated end organ damage, or patient has got pregnancy, or patient is in competitive sports, etc. These are the group of situations where you might think of referring the patient to a hypertension specialist or co-manage with a hypertension specialist. Current guidelines for initiative antihypertensive treatment are based on 10-year cardiovascular risk, which needs to be rethinking, and we need to have more data of lifetime risk or a 30-year risk in a younger population of patients. Lower blood pressure targets may be considered given the lifetime risk faced by younger patients. Although this recommendation is not directly supported by randomized trials, it's kind of expert opinion based. Thank you very much for your patient listening. And now I would open the talk for question, comment, suggestions, if any.
Thank you so much, Jason.
And these are my contact details. In case if you miss to ask question, if I miss to answer your question, you can note down my email, and you are free to shoot me an email with your question, comment, suggestion, etc. With that, I would stop sharing my slides, and let us go to the discussion part. Yes, Anika, if you have the questions, you can shoot now.
Yes, sir. There are a few general questions and there are a few.
Your voice is very, very low.
Okay. Is it better? Is it?
Sorry, it was a problem on my side. Volume was low. Now it's better. Tell me.
There are very specific questions as well as there are general questions. So we'll start with the specific ones. A 30-year-old female has elevated blood pressure of 150 by 100 average with no comorbidities but has angiomyolipoma of the kidney. Which BP medicine is contraindicated and which BP medicine should be prescribed in general?
So 30-year-old lady, 150 by 100 blood pressure and angiolipomyoma of the kidney.
Yes, sir.
All right. I think if angiomyolipoma can be treated as per its requirement, if that is a obstructive kind of growth and if it is constricting the kidneys, then there is an indication for specific treatment of angiomyolipoma. If it is not obstructive, then it is just a bystander. And if it is a bystander, probably this patient needs to be screened for other causes of secondary hypertension. And if there are no other causes of secondary hypertension are found, because the age is 30, I would kind of advise them lifestyle modification for 6 months. Failing which, if the pressure does not come under control, then I would prescribe an antihypertensive therapy. So first, rule out renal vascular involvement. If the angiolipomyoma is localized, treatable, and compressing, then you go ahead and treat it surgically, or whatever appropriate therapy for that may be. Secondary causes to be ruled out. If there are other secondary causes are there, comorbidities, then you take care of that. If you fail lifestyle therapy, go ahead with the specific pharmacotherapy. If the patient is planning to become pregnant, I would start with kind of beta blocker therapy. Even calcium channel blockers can be an add-on. Hydrochlorothiazide should not be a problem as a third line agent. No ACE inhibitor, no ARB if the patient is planning to become pregnant. That's what roughly I would think of a kind of a flow chart for this patient. How would I manage over a couple of months or year or so?
Thank you for that answer. We have another question by Dr. Rangarajan here. Patient is 41-year old, had nephrectomy due to injury when young. His present BP is 127 by 81, high normal, and he's a non-smoker, non-diabetic, non-alcoholic, within the normal range. Weight is within the normal range. How should he be treated?
127 by 91.
81.
81. uh,
Sir, before you start
120.
the answer,
Sorry.
can you before you start the answer, can you please stop screen sharing so that we
Sure.
can see the questions? Yes.
All
Yes.
right. So 127 by 81, technically it falls in the criteria of either 130 or 80 above. With just 1 millimeter of mercury, I would not be pushing him for, since he had a nephrectomy. I am sure that young person would be far more receptive to lifestyle modification. So I would go for a very aggressive lifestyle modification in this patient. Wait for 6 months. I am sure from 127/81 it can come down, and I believe that blood pressure is based on out of office blood pressure measurement. Office blood pressure measurement, I would not be relying much on this young patient. I would not be putting him on a lifelong antihypertensive therapy just because diastolic pressure crosses one. But I would encourage patient to buy a blood pressure machine and measure it every couple of months, and maybe an annual checkup. With a single kidney, we would not like to compromise that at all.
Uh, Dr. Jayashree has asked, in hypertrophic cardiomyopathy in the young, which antihypertensive drug is advisable?
Uh, Hypertrophic cardiomyopathy patient, you can consider beta blockers as the first line therapy. Hypertrophic cardiomyopathy in itself might be needing, if the patient does not have, if the patient has arrhythmias, again, if there is a significant ventricular tachycardia, or there is a history of syncope either in the patient or in any of the affected family members, then patient would most probably be going for an ICD to reduce the chances of sudden cardiac death, which would be very high. Short of that, if there are lesser severity ventricular arrhythmias, you can think of beta blockers, because in hypertrophic cardiomyopathy, hypercontractile LV is one of the pathophysiology. So beta blocker would be the drug of choice. I would avoid vasodilators. So vasodilating beta blockers like nebivolol or carvedilol, I would not be looking into, because we know that in hypertrophic cardiomyopathy, the obstructive variety, the obstruction worsens with vasodilatation. When you vasodilate the patient, left ventricular size comes down and the left ventricular obstruction shoots up like anything. So regular beta blockers, non-vasodilating beta blockers, carvedilol, nebivolol would be avoided. Bisoprolol, metoprolol would be welcome. Second choice, if needed, would be uh, RAS blockade, ACE inhibitor or ARB if it is not controlled with beta blockers. Diuretics I would be using sparingly, but third choice would be diuretics. Fourth would go into probably spironolactone or mineralocorticoid receptor antagonists. That's how I would manage a patient with hypertrophic cardiomyopathy if he has obstruction. If he does not have obstruction, then possibly calcium channel blockers also can be added without worrying about increasing the left ventricular obstruction. Among the calcium channel blockers, again, verapamil and diltiazem, which reduce cardiac contractility, would be helpful provided his heart rate permits. After giving beta blocker, if his heart rate is 75, 80, we have a margin where diltiazem or verapamil will be tolerated. But on beta blocker, if his heart rate has dropped to 60, 65, you cannot add another rate reducing agent.
Uh, we have a couple of questions about digital equipment and the our sphygmomanometer BP instrument. Uh, which is better at home, and can the patients use the digital one, and is it reliable?
Digital manometers are quite reliable. The load cell, which is used to sense the pressure, that does not drift. So digital manometers need not be calibrated. Unlike those aneroid blood pressure monitors, which upon the elasticity of a spring inside the blood pressure monitor, that spring changes its elasticity. So those needed to be calibrated every 6 months. The mercury manometers are very cumbersome, and for the patient to be trained on that, it's very difficult.
Yeah.
Secondly, because of the environmental impact of mercury, mercury manometers are no longer allowed to be manufactured, transported, or sold. So they are practically out. And there are hundreds of manometer. If any in doubt, you can go to British Hypertension Society website, and they have a certified, more than 100 certified blood pressure manometers which are certified. You can use any of them. Short of that, in my opinion, in my practical opinion, I have been asking my patients for last almost a decade. More than 1,000 of my patients must be using. I feel that any manometer is as good as anyone. I have not found grossly abnormal reading with even non-BHS certified BP manometer. So that technology is so perfected that I think electronic machine is the way to go. Last 7 8 years in my clinic, I don't use mercury manometer. It's being done, and even I don't measure blood pressure. I ask my staff outside to measure. Any patient who questions the quality of that measurement, I take the same machine and measure inside my chamber, and it's 10 to 20 higher.
Yeah.
And then I ask the patient, okay, take this machine home, check it for a day, and come back, and at home it is normal. If he has a BP machine at home, and if he questions that at home my BP is like this, I ask him to bring his machine and measure with my machine and his machine in the same room simultaneously. So it's a kind of quality test or a comparison between the two, and it has
Yeah.
never.
Thank you, sir. Dr. Batul Bora has asked, how do you tailor antihypertensive choice in a young adult with subclinical hyperuricemia or gout tendency?
If the patient has a tendency for gout, what you can use is losartan. Losartan is the one which has a tendency to reduce uric acid, and diuretics, particularly chlorthalidone. The stronger and longer acting the diuretic, more the chances of hyperuricemia. So chlorthalidone is one which I would probably try and avoid. Another thing now with bempedoic acid as a third line dyslipidemia therapy, I would be more careful if the patient needs that, because there is bempedoic acid has a significant elevation in uric acid. Not only that, that hyperuricemia can affect the tendons, and it can cause tendon rupture. Achilles tendon rupture or forearm tendon ruptures are something which is not unheard of. So I would use losartan more liberally, but a borderline uric acid elevation, nobody knows, if your uric acid instead of 7, it's 8 or 9, whether it needs to be treated or not. I would liberally use, I would rather control his blood pressure and reduce cardiovascular endpoint by 25-30% than a small chance of a cosmetic uric acid elevation, which can easily be taken care of by using anti-hyperuricemic drugs like Febustat or Xyloric or something like that. So I would not focus much on it, except that I would ask him to follow a lifestyle to reduce uric acid, protein intake, etc. Monitor his uric acid maybe once or twice a year. If the patient did not have gout, I would not put a great focus on that. And if I need to focus, then losartan, bempedoic acid, more careful, chlorthalidone, avoid use, milder diuretic, smaller dose of diuretic, if at all you need to use it.
Okay, thank you, sir. Uh, Dr. Rangarajan has another question. Isolated diastolic hypertension of 115 by 90. How do we approach this patient?
115 by 90, as always, reconfirm whether patient is really hypertensive. Out of office blood pressure, multiple home blood pressure monitoring, ambulatory blood pressure. If everything confirms, isolated diastolic hypertension in young adult needs to be treated,
Yes.
and it is because of the Probably that patient might be hypertensive from his neonatal age or a pediatric age, and over the years he has an accelerated vascular aging, or he has an increased peripheral resistance. The sympathetic drive might be high, not just increase in cardiac output, but stroke volume has not gone up, but peripheral vascular resistance has gone up. So this group of patients, I would rather use, particularly if the patient has other evidence of sympathetic overdrive, like his heart rate remains at rest above 80. In that case, I would use a beta blocker with vasodilating property. That is carvedilol, nebivolol. These are the two beta blockers which have a vasodilating property. Those would be the first choice. But any other antihypertensive agent which you are comfortable with should be okay. Uh, if the patient does not have tachycardia and tolerates amlodipine well, then even amlodipine as a vasodilator would be a good choice. But that is just so far as first choice of agent is concerned. If there is any problem with this agent, there is no hesitation in using any antihypertensive agent from the classes available to you.
Yes, sir. Just following up on that, for an age group of 40 to 50 years in both genders, what should be the choice of antihypertensive?
Between 40 to 50, we would go for the standard choice of agents first line therapy as recommended in guidelines. By the age of 40, you have a risk calculators also, so you know by that time already it's a little late. I would go ahead and treat them aggressively, and the standard protocols for elderly hypertensive patients would apply there.
Yes. Uh, for a patient aged 85, what should his normal BP be, and at what level should we start treating him?
Again, it depends upon what risk group patient falls in. If by the age of 85, if the patient has not developed heart failure, if his renal parameters are okay, eGFR is 80, 90, if his retina does not show hypertensive retinopathy, if his coronary calcium score, which highly likely that he has done, and calcium score is not high, less than 100. If you do his carotid screening on ultrasound, which I do it routinely in my clinic for majority of patients who come to me with any cardiovascular risk factor, or they come for a routine health checkup, just rule out heart disease. I do carotid intima media thickness because I was a part of the trial where what is normal carotid intima media thickness in Indian patients. So my center was one of the centers. I have done it in hundreds of patients. And what is normal carotid intima media thickness in India is based on the trial which we had conducted. That was around 15 centers across India. So I'm very strong fan of CIMT. It's very easy, it just takes hardly a minute or two to screen carotids and find out intima media thickness, find out carotid plaques. If none of those things are there, even 150 by 90 blood pressure I would tolerate. Otherwise, if the patient falls into high risk category, if he has any of the end organ damage, my criteria would be 140 by 90 in 80 plus population. And my target would be 130 by 80 if tolerated. As compared to young people, I would be starting with a smaller dose of antihypertensive medications. I would ask the patient to monitor blood pressure at home, not only seated blood pressure, but to rule out any postural hypotension, which ultimately leads to fall and fracture. I would ask every patient to check his blood pressure in standing posture also. And in standing pressure, if blood pressure starts dropping with an amlodipine of 2.5 milligram, I would not step up the dose. If he tolerates it very well, no postural hypertension, no postural dizziness, then my target would be 130 by 80 at any age, if tolerated. And that tolerated becomes a big question once the patient crosses the age of 70, 75.
Dr. Adraval has asked the drug of choice in a diabetic young hypertensive.
Diabetic young hypertensive, again, if it is young, look for sympathetic overdrive. I'm a fan of beta blockers in hypertension, and in young patient quite frequently. Like today, one of the last patient I saw, he had a heart rate of 120 for last 10 years ever since he's measured, totally asymptomatic, and blood pressure is 135 by 82 on repeated measurements, ABPM, everything done. I have started him on beta blockers. So young diabetic patients, if sympathetic overdrive is there, I would go for beta blockers. If that is not there, then RAS blockade, ACE inhibitor, and ARBs would be the drug of choice. If the patient has more than stage 1 hypertension, then probably a single pill combination of RAS blockade plus beta blockade. And nowadays, lot of combinations are there. In a young patient for beta blocker, I would go for a super selective beta blocker as bisoprolol or nebivolol, because these patients may be sexually active, and we don't want to have erectile dysfunction interfering with their quality of life. So these are few of the thoughts which I would put in. But ultimately, if the first line therapy fails or does not tolerate or anything happens, any agent is as good as any other agent. What is more important is control the blood pressure, not how.
Yes, sir. I'll just take a few more questions. There are many more. I'll just combine a few and take. Uh, a middle aged female, 55 years of age, has no comorbidities and has a strong family history of diabetes, hypertension, CKD in one parent, and is found to have BP of 180 by 90. For what should be the first line therapy be? And I'm guessing it's non obese and initial metabolic workup is all normal.
All right, so 55, no other comorbidities, strong family history, blood pressure is very high. Rule out the white coat hypertension, measure the blood pressure properly repeatedly. Since she does not have any other comorbidities, waiting for a couple of weeks till we know her real blood pressure uh, is okay. If the patient had come with, say, angina or heart failure or worsening renal parameters, probably I would have started the therapy on the first day. Otherwise, I would be looking for the correct out of office resting blood pressure. If that is found to be elevated, and obviously lifestyle therapy would start from day one, even if she ultimately comes to be non hypertensive, lifestyle therapy is going to help in a big way. Along with that, my choice of agent would be ACE inhibitors or ARB, because there is a family history of diabetes as well as CKD. Diabetes and CKD progression gets prevented with ACE inhibitor ARBs. We use it in patients with EGFR above 30 to prevent the progression of renal failure. Even SGLT2 inhibitors are there if the patient had some amount of renal dysfunction. If EGFR was less than 60, I would have even put her on SGLT2. But here, since all parameters are normal, ACE inhibitors or ARB would be the drug of my first choice. The second agent can be anything. It could be diuretic, it could be calcium channel blocker, or it could be beta blocker if you find parameters of sympathetic overdrive.
Yes, sir.
And among that, telmisartan would be preferable, because one parent will be being diabetic, she can be labeled as pre-diabetic, and with that, the insulin sensitizing effect of telmisartan would come in handy, whatever it is worth.
Uh, this is a rather specific question. Could the long term use of SSRIs or ADHD stimulants contribute to sustained BP rise through the sympathetic overdrive?
Not much heard of. I have not come across much of the literature saying that long-term use causing sympathetic overdrive. Even on sympathetic overdrive, I have reviewed a lot of literature. I have not come across. If he has come across any paper, I mean, I would be happy to know about it.
Yes, sure. Dr. Jayashree has asked, can you comment on the combination of antihypertension drugs and which are frequently used now? Is it advisable?
Yes, we are the combination capital of the world. We combine all kind of rational and irrational drugs. We also combine dapagliflozin and beta blocker. We combine dapagliflozin and pioglitazone. But in hypertension, what we had done is now adapted by the Western world, even in US. Single pill combination of two drug and even three drug is now available in USA. We in India were the first to try start. It is olmesartan, amlodipine, and chlorphenidone combination is available. There are lots of combinations available. Beta blocker and AC beta blocker and ARB, different type of beta blockers and different type of ARBs like telmisartan with metoprolol, telmisartan with bisoprolol, telmisartan with nebivolol. Similarly, different diuretic combination in true drug combination we are talking about. Classical combinations were telmisartan with calcium channel blockers, which was amlodipine, now cilnidipine, and triple combination starting with telmisartan or ramipril and adding calcium channel blockers, diuretics, uh, beta blockers, different ones. So, n number of combinations are available. All are as good. So far as there is a justification of using each individual agent, you can use the combination. Only pitfall is if sometimes if the patient get you give telmisartan amlodipine 40 plus 5 and 5 milligram amlodipine causes tachycardia, palpitation, pedal edema, headache, then you cannot combine, you cannot reduce amlodipine alone. You have to come down, and you have a tendency to maintain a single pill combination which you have given. So in those specific situations where a single agent patient does not tolerate the fixed dosages which come with combination, you might have to separate it out. But with the number of combinations which are available, if your patient does not tolerate amlodipine, go ahead with cilnidipine combination, go ahead with azilnidipine combination, which does not cause that much of reflex sympathetic stimulation, reflex tachycardia. So the options, we are spoiled for choices.
Uh, I'll just take one more question. We have many. I can share them on WhatsApp to you, sir. Then you can have answer them. I'll share the answers with the participants later.
Let them share directly with me. It would be great to discuss with them. My email ID and WhatsApp number was already given to them.
Yes, sir. So, what is the role of antihypertensive drugs in COPD, and what is the role of Lasix in such patients?
Uh, COPD antihypertensive drug. The most common myth is that in COPD you cannot use beta blockers. You can use beta blockers. In fact, there is enough of data to say that COPD patients have a reflex increase in sympathetic drive, and giving beta blockers improves cardiovascular outcome. And selective beta blockers like metoprolol in a small or a moderate dose as 25 or 50 milligram, the selectivity is much higher. It does not worsen the bronchoconstriction. It does not worsen the airway resistance. And now we have a highly selective beta blockers like bisoprolol, and still more selective. Highest selective beta blocker is nebivolol, and there you practically don't get any worsening unless there is a severe COPD or acute exacerbation. You don't need to use it. The use of Lasix in COPD is only if the patient has congestion. Otherwise, Lasix is not a great antihypertensive agent. For antihypertensive agent, we go for more of a thiazide-like or thiazide-type diuretics like hydrochlorothiazide, chlorthalidone, and indapamide.
Yes, sir.
Apart from that, any other antihypertensive agents can be used in COPD, but don't hesitate to use super selective beta blocker in small to moderate dose if it is required. In fact, it will improve it will reduce the chance of atrial fibrillation, arrhythmia, sudden cardiac death, and overall cardiovascular outcome.
Thank you so much, sir.
Pleasure.
And that brings us to the end of the Q&A and the session for today. Thank you so much, sir, for joining us and sharing your incredible insights with us today. Thank you for all the audience members for joining.